evening, everybody. My name is Kathy Antela, Vice President of Education at the Immunodeficiency Foundation, and would like to welcome you to this IDF forum, COVID-19, What We Know Now. The forum is being recorded, and the recording will be available within the upcoming week on the IDF website. And also after the forum, everybody will receive an email, and in that email will be a link to a very short survey to let us know how we did with tonight's program. And it will also include an opportunity for you to tell us what you'd like to hear about at future forums. As always, a disclaimer. Please remember that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified healthcare provider with questions concerning a medical condition. Please never disregard professional medical advice or delay it based on information presented during this event. For over 40 years, the Immunodeficiency Foundation has served as the trusted organization for the primary immunodeficiency community, with a mission of improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. And we do value our role as a patient advocacy organization. As a result of our mission, IDF seeks to ensure that everyone in the United States affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all their opportunities for connection and support within the PI community. Whether you are an individual with PI, a family member, friend, or a healthcare provider, IDF is here to help. When you have questions about living with PI, health insurance, or more, simply go to the IDF website, click on Ask IDF, submit your question, and a staff member will follow up with you. Are you looking for support? If so, one option is to attend a virtual IDF Get Connected group. These groups are exclusively for individuals with PI and family members. They are led by our amazing Get Connected leaders. They are scheduled nationwide throughout the year and are a great way to meet others and receive support in a small group setting. Another option, if you prefer one-to-one support, send a request for peer support via Ask IDF, and you'll be networked with one of our wonderful peer support volunteers. IDF forums are made possible by our partnerships with our wonderful sponsors. So right now, I would like you to join me in thanking our 2022 sponsors: CSL Behring, Grifols, Takeda, Horizon, Accredo, Octapharma, Farming Healthcare, ADMA Biologics, AstraZeneca, Bioproducts Laboratory, Kedrion Biopharma, Enzavant, X4 Pharmaceuticals, and KSE Global Rare Diseases. During tonight's program, we do look forward to hearing from some of our sponsors in person and also via video. So thank you. Thank you, sponsors. And speaking of our sponsors, right now, we're going to have a word from our sponsor, Grifols. So Ricky and Alex, it's going to take me just a second because we had some little glitches in the beginning, but I am going to take a second to switch you over to be a panelist, and you then will be able to unmute yourself and share your screen.
My name is Ricky Mensch. I'm one of Grifols' IG nurse educators. I'd like to talk a little bit about plasma donation this evening. Because you get so few grams of Ig per liter of plasma and Ig cannot be produced synthetically, it can take up to 130 individual donations to treat one adult with PI for 1 year. Because of this, Grifols is heavily committed to plasma donation awareness in an effort to encourage a sustainable supply of plasma medicines for those who need them. Though your friends and family members without chronic or relapsing medical conditions could be eligible to donate, and with over 300 donation centers in the US, there's very likely a Grifols donation center near you. But regardless of which manufacturer's donation center you choose, that gift will benefit patients the world around. I'd like to introduce you to my partner, Alex Lowe, who is Grifols' specialty representative based in Sacramento, California. Welcome, Alex.
Hi, everyone. I wanted to actually discuss diagnosing patients with early onset symptoms for PIDD while living in the current climate we all have been for the last couple of years. At Grifols, we've teamed up with our pulmonary counterparts in screening patients who come in to see their physicians due to getting reoccurring pneumonia. It has been common for some physicians to actually see an adult 2 to 3 times throughout the year, and seeing these lung issues as actually COVID-related symptoms. However, healthy adults should not be getting reoccurring pneumonia. So these patients need to be tested and screened for PIDD so we can see those IgG levels in order to diagnose PIDD early on. Being able to diagnose a patient with PIDD in the early stages is so crucial so the patient and their family can get tied into wonderful support networks like the IDF and start managing their symptoms. So Grifols actually offers a beautiful copay assistance program for patients needing Gamunex 10%, for IV Ig therapy, and for Xembify 20% for patients needing subcutaneous Ig therapy. But at the end, our goal is to not have any patient symptoms fall through the cracks and allow PIDD patients to live a life that is empowered and full. That's it.
Thank you, Ricky, and thank you, Alex. Wonderful to have you here and wonderful to have your support. Thank you for everything you do. And now I would like to introduce Dr. Hartline from Pharming to share a few words with us. So please take it away.
Thank you very much. Good evening, everyone. My name is Brian Hartline. I'm the Senior Medical Director at Pharming Healthcare. And my goal tonight in these next few minutes is to give you a little insight into who we are as a company and what our main focus is. Next slide, please. So we are a global company. We're a commercial stage biopharmaceutical company, really focused on developing very innovative protein replacement therapies and various precision medicines for the treatment specifically in the rare disease area with a main focus on unmet medical needs. As I mentioned, we're a global company. Our 2 main offices, one is located in Leiden in the Netherlands, and our US office is based in Warren, New Jersey. We're a company that's continuing to grow, not only globally, also from an employee standpoint as well. So as I mentioned, we kind of focus our our research in the rare disease areas, and our current product candidate portfolio is focused on the rare diseases of HAE, or hereditary angioedema, activated PI3K delta syndrome, or APDS, and Pompe disease. Next slide, please. So as I mentioned, even though we're kind of focused in quite a few areas, one of our main focuses right now is APDS. APDS is a relatively newly characterized disease, which was characterized back in 2013. So that's really only about 9 years ago, which is not that long. The prevalence of the disease is really not well characterized either, but from some data that we have and understand, it affects about 1 to 2 million, 1 to 2 people per million worldwide. So that's a very, very ultra rare disease. So I want to tell you just a little bit about APDS. So it is considered a primary immunodeficiency disease, and it is caused by variants in a couple of specific gene types. One is called the PIK3CD, and one is called the PIK3R1 genes. What happens is these variants, which are, as I mentioned, are genetic, can actually alter and affect how your B and T cells function. And so this leads to issues both from an immune deficiency, meaning this can cause an increase in frequent and recurrent infections, and it can also cause what we call immune dysregulation, which has all kind of complications associated with these different B and T cell abnormalities. Now, I mentioned that it was a variant in these two genes, and typically it is what we call inherited in an autosomal dominant manner, meaning that it really only requires one person in either the mom or the dad to have that gene to pass it down to their child, and their child has a 50% chance of developing that disease. But there have been reports where this genetic variation occurs de novo, or means spontaneous, meaning that it was not passed down from the mother or the father to the child. Now, it can present itself with a wide variety of clinical features, symptoms, manifestations, depending on how you want to look at it. Most common is severe infections, mostly in the sinus and pulmonary regions, as well as what we call lymphoproliferation, which means patients can have swollen lymph nodes, or they can have enlarged liver and spleen, but they can have GI issues, they can have different types of neurodevelopmental delays. So there's a whole host of issues that can arise that these patients present. And also, because they can present in such different ways, it makes the disease a little bit difficult to diagnose, because it can mimic many other type of diseases that are out there as well. Next slide, please. So because of these wide-ranging of clinical manifestations that patients can have, really kind of the only way to definitively diagnose APDS is with a specific genetic test. Both Farming has partnered with Invitae. We have a program called Navigate APDS, which is a no-charge sponsored genetic testing program that is available to physicians and to patients. We have a couple of different gene panels within that does include testing for APDS. And because this is potentially a disease that can be passed down from in families, have the ability for the no-charge testing, genetic testing for the close family members or appropriate family members of those patients that actually have APDS. So the important thing to kind of remember for people is, if you have some concerns with these type of manifestations, or if you have APDS or know someone who does, feel free to reach out to your healthcare provider, for more details about the disease, as well as for the genetic testing program as well. So with that, I thank you for your time.
And thank you, Dr. Hartline, for this great information and for your support of IDF and the PI community.
You're very welcome.
At this time, we are going to get started with our presentation from Dr. Pham. So Dr. Pham, I'm going to pull my slides down and you can pull yours up and we will get started. So I am honored to introduce Dr. Michele Pham. Dr. Pham is an assistant professor of medicine and associate chief of allergy and immunology for primary immunodeficiency at the University of California, San Francisco. So please join me in welcoming Dr. Pham tonight. Thank you.
And sorry for my voice. I'm recovering from laryngitis, but hopefully everyone can hear me well. So today I'm gonna give you an update on COVID and what we know so far, but focusing on topics that would be particularly interesting in patients with primary immunodeficiencies. And so I'm going to focus today on current state of infections and variants, particularly the Omicron variant, talk about vaccinations and updates, as well as preventative therapies for infections and treatment for COVID-19. So where are we today? This is a schematic from the CDC reporting daily cases and trends of COVID-19 cases in the United States reported to the CDC. So as you can see here, we definitely had a surge in cases this past winter, and cases now are on the lower end and a little bit plateauing. Per the case reports, the reports of cases just this past week, it seems like the trends in case reports seem to continue to decrease over the last couple of weeks. And so the new daily average reporting cases for the US is 82,000. And total cases so far reported to the CDC of COVID since the pandemic started is at 94 million. So out of all the people in the US, that is about a quarter of the population of the US. But we know that underreporting is a big issue with cases here, because in the US, we rely a lot on home antigen testing. And so we know based on studies that the results aren't always reported. And so one study looked at 4 testing brands and only saw that 3% of those tests that were used were ever reported to the CDC. So definitely we're missing cases being reported, but overall the trend looks like it's decreasing and stabilizing, but we're entering into the fall. And so similarly, with regards to hospitalizations and deaths, it seems like the trends are decreasing over the last couple of weeks. And then with community COVID-19 infection levels by county, in this map, it shows low transmission rates in green, medium in yellow. The orange ones are high transmission rates. And with regards to, I guess, locations of the US, there seems to be high transmission rates more centrally and in the South, and also in parts of like big cities, California, Alaska. And so about 29.5% of the US is in some type of high county with high transmission, and then 42.9% are in a moderate level, and then 27.6% are in the low. And District of Columbia, Massachusetts, Nevada, and Rhode Island are the only jurisdictions where all the counties are at low community levels. And the rate of low, high, moderate are determined by like hospitalization rates and infection rates. And so where are we with regards to vaccination rates? And so vaccinations have been available for more than a year against SARS-CoV-2. And about 80% of the US population has received at least 1 dose of the COVID vaccines. 67.4% are fully vaccinated. So they're counting that as 2 vaccines. And now there's boosters available as well. And so for people who are eligible, children and adults older than 5 years of age, about 48.5% of individuals have received 1 booster, and about 33.7% of those eligible have received a 2nd booster. And so over time, we've seen the virus change since it first emerged in 2 years ago. And so with the original virus, it has mutated and progressed to different variants. And so Alpha was a variant that we saw early on. Beta is something that we saw in 2020. Delta was something that we saw in 2021. And now we're seeing the variant Omicron and then the subvariants. So there's variants and subvariants, BA1, BA2, BA4, BA5. So at a time, these variants become predominant and then decrease, and then new ones likely will emerge. Variants are expected because a virus will always try to grow and change and try to find ways to become more infectious. And so with regards to the monitoring for variants of concern, the CDC does label variants and do label variants based on the risk of what they feel like will emerge as a leading variant. And so right now, the only main variant of concern is Omicron. And so that has been predominant and is thought to be 100% of cases in the US right now. And this schematic is interesting because it breaks down the variant proportions and so into the subvariants. And so you can see that over time, the subvariants BA2 are getting less, but BA5 and BA4 are becoming more predominant with time. And right now, currently, BA.5 is making up 88.7% of COVID cases, and BA4 is making up 7.5%. And so the way that they capture these variants is some of the tests that are collected will be sent for further evaluation. And then so they break it down and further sequence it and try to figure out and estimate what percentage of the whole population of infections are due to these variants. And so BA4 and BA5 have emerged because they've been able to escape the antibodies raised through infection and vaccination. And so BA4 and 5 have mutations in the spike protein area that the virus uses to get into the cell and infect the cell. And so it's a really important area for, in general, for the virus and also for our immune responses, because a lot of our therapies and vaccines are targeted at the spike protein. And so given these mutations, so BA4 has some mutations, BA5 has even more mutations at the spike protein site. And so it's allowed them to evade these antibodies that have been made against the spike protein site. And so there's also some data showing that they have greater replication advantages. And so patients can get higher viral loads that would potentially make them more infectious. And it's interesting though, because there was a study that looked at individuals who had COVID infections early on in the Omicron wave, so earlier on in the year, and they found that those who so the blood of those who were vaccinated and had the BA1 Omicron variant infection had higher neutralization against BA4 and BA5 compared to those who only had the vaccination. So definitely the vaccine helps provide like a broader response, an immune response to the COVID variants as well. And so BA5 in general has been associated with less severe disease compared to some of the other major variants. And so the data so far show that there's a reduced risk of hospitalization with BA5, ICU admissions decrease, and as have in-hospital mortality. But though, even though illness due to Omicron in general may be milder, there tends to be a higher volume of cases because it's so infectious. And if there's a lot of cases, and that might cause some like an excess burden on the healthcare system. So still good to be able to prevent disease when you can. And so with a COVID-19 infection, when someone gets exposed to a virus and becomes infected, they typically will develop symptoms within an incubation period of about 14 days after exposure. Most cases will occur between 3 to 5 days after exposure. The Omicron variant has seemed to cause symptoms sooner. So typically around like 3 days, patients will note symptoms. The period of infectiousness seems to be similar, but we're still collecting data. You tend to be more infectious in the earlier stages of the infection, so starting a few days before you develop symptoms, and then transmission post 7 to 10 days of an illness is unlikely. And that has influenced the recommendations with regards to return to work and isolation, quarantining as well. Of course, patients can shed the virus for a prolonged period of time, and that has particularly been reported in patients who are immunocompromised. In the general population, patients can have shedding for like 11 days from the infection, and then in immunodeficient patients, on average, it has seen, like, especially in moderate to severe patients with immunodeficiency, the thought is that they might have shedding for about 20 days. And so in certain institutions, patients with immunodeficiencies who get COVID, they might have to quarantine for 20 days, or if they need to go to the infusion center for the IVIG, you might have to go to a COVID specific room for that period of time. But just because they're shedding, it's not clearly associated with prolonged infectiousness, because there definitely are patients with who can have shedding for like 2 months, 3 months as well. And a lot of it could just be like the viral particles and proteins itself, not the full virus. And so symptoms of BA4 and BA5 are pretty similar to the other SARS-CoV-2 variants, but particularly for this wave, cough, fatigue, runny nose, sore throat, headache are common. Patients can, of course, get shortness of breath, GI symptoms, fever, change in taste or smell as well. And it's interesting because there seems to be a poor awareness of Omicron infections. And there was a study in Los Angeles in just like a longitudinal COVID-19 blood study of adult employees at a LA hospital system and also their patients. And so they would routinely take blood work, and they found that of patients who had a recent Omicron infection, 56% were unaware that they did have an infection, and 10% of those patients had mild symptoms they thought were just the common cold. And so this data was collected during like fall of 2021 and May 2022. And so probably the low awareness of an Omicron infection also increases the rapid transmission of the Omicron virus as well. But potentially that can help skew things towards the herd immunity, where patients or where a community has protection from a virus because so many people have immune responses or an infection, they have immune responses that protect other people as well who might not be vaccinated or might not have good responses to vaccines. But as we know with COVID, reaching herd immunity and having it be protective is a little bit complicated because there have been reinfection cases and our immune system seems to do wane over time from the vaccine responses, even with a normal healthy immune system. And so with regards to reinfection with COVID, the COVID virus, it's been reported in the prior years, but definitely more common now. The highest reinfection rate has been observed with the Omicron variant. So it's been estimated that the Omicron variant is 30 times, well, patients are 30 times more likely to get an infection during the Omicron variant period than the Alpha variant. And then the reinfection rate for Omicron is 10 times more frequent than the Delta variant. And so there was a study in Turkey that looked at 27,000 individuals and looking just throughout like the alpha wave and the Delta wave and up until January of this past year. And they found that the farther people were from their prior COVID infection, of course, they had a higher likelihood of getting COVID. And so of reinfection rates, 16.5% got COVID again for a second time, 3 to 6 months after their initial COVID infection. 36.7% had it after 6 to 12 months after their last infection, and then 4.6 or 46.8% had it over a year after their last infection. And so the risk of reinfection increases with the emergence of new variants as time goes on from your last infection or vaccine. And then as society opens up and precautions aren't as adhered to as strictly. And with regards to BA.5 specifically, there's limited data as to whether or not a person can get BA.5 twice, but unlikely that it would occur within a month. But in theory, as like your immunity wanes from the infection or the vaccine, you could get it again. It just more likely would be a different variant as time goes on. And so with COVID and immunodeficiencies, we know that, so immunodeficiencies affect about 3% of the whole American population. And we know that people with immunodeficiencies have a really wide range of the way they present and their issues and symptoms. And so, as you can imagine, then COVID infection in this population varies significantly. And it tends to adhere more to, like, the risk of severe COVID tends to be seen more in patients who have other risk factors, like patients who are older, patients who have lung disease, heart disease, kidney disease, other immunodeficiencies. They tend to have a higher risk of severe COVID. And then with regards to PID, there have been some immune issues that might be at higher risk of severe COVID, like patients with innate immune issues, like interferon issues, T cell issues, because you need the T cells to clear the infection. That might cause a higher risk for severe COVID. And then with regards to Omicron specifically, there's no data yet with regards to how PID patients are faring. But we're gathering information, and I guess with any type of information, there's always like a delay in reporting. So prevention of an infection is really important, especially in our population. And so I'm going to talk about today vaccinations and updates, continuing to maintain precautions, and then receiving Evusheld as a COVID pre-exposure prophylaxis if you're eligible. And so for general precautions, for my PID patients or patients with secondary immunodeficiencies, I still recommend that they try to avoid people who are sick, that they wear a mask, especially in indoor settings or in settings where they will be in closer proximity to people. And if they don't, especially if they don't know the vaccine status of individuals. But as you know, even people with vaccinations can have COVID. The higher the quality of the mask, the better, or the more protective. And so respirators like N95s and KN95s are particularly good, especially if you're going to go in a higher risk setting like a concert or flying on an airplane. But in general, I tell patients to avoid poorly ventilated or crowded indoor settings. It's always safer to gather outside than indoors. And when you are indoors with others, try to improve ventilation when you can. So like fans by the windows indoors, opening the windows indoors, HEPA filters can help, HVAC systems can help. So of course, always being cognizant of where your hands go, washing your hands frequently, or using hand sanitizer with at least like 60% alcohol in the content. And then just being cognizant of doing, like, washing your hands before touching your face, your eyes, your mouth. And so this is an interesting image I found on the CDC website, where talking about like the effects of, or displaying the effects of ventilation, good ventilation and poor ventilation. So these dots are supposed to signify like viral particles. And so if there's no open doors, no fans, no portable air cleaner, then an hour later, there's still a good amount of viral particles in the air. With good ventilation, with a ceiling fan, open windows, exhaust fan blowing, air outside, portable air cleaner, potentially an hour later, that space could be cleared. And so it's always good to keep air moving if you need to gather with people indoors. And so vaccines are very critical to providing protection in the community in general. And I definitely do still recommend vaccinations for my PID patients, even if there's a thought that, like, even for like XLA patients who might not make antibodies, because these vaccines can stimulate other immune cells to help fight infections as well. And so in the US right now, there are 3 major groups of vaccines that are approved for patients. And so mRNA vaccines, you know them well. They give you, they're a new class of vaccines, but they've been really effective during this pandemic with regards to giving protection. So with the mRNA vaccine, it instructs your cells through mRNA to make a piece of the spike protein, and then your immune system will look at it and then respond to it. And so there's two major ones offered. So the Pfizer and the Moderna vaccines. So in the original studies, in the original vaccine trials and like healthy individuals, the Pfizer vaccine was 95% effective in preventing symptomatic infections and 100% effective in preventing severe COVID. So similar cases, Moderna. In the later year, as infections, as the variants changed, Moderna seemed to be a little bit, there's some limited data about Moderna being a little bit more effective against things like Delta, but there needs to be more robust data for that. And I would say that it's hard to, it might just be study specific. It's hard to favor one over the other. We'll just get what's available and readily available to you. There's also a new vaccine approved in the US. It's been approved abroad for a while. It's the adjuvant recombinant protein vaccine, Novavax. And so it contains proteins of the virus. And so your body will see the protein and stimulate an immune response. And so this technology has been used for the HPV vaccine, hepatitis B vaccine, and that was effective in preventing 89% in their trials of symptomatic and severe COVID. And then there's also the adenoviral vector vaccine, the J&J, which used a weakened virus to deliver material to teach your, to make the S protein and to teach your immune system to mount our immune response. So that was effective about 66% in preventing symptomatic disease, and then 85% in severe COVID in their trials. We're actually basically phasing out the J&J vaccine and relying more on the mRNA and potentially the Novavax too. And so for patients with immunodeficiencies, there have been extra doses recommended and boosters in order to stimulate a good immune response or stimulate the most optimal response as possible. So for Moderna and Pfizer, it's approved for patients basically 6 months and older, but for adults and generally kids over 12, the initial vaccination series is comprised of 3 doses, and then now a first booster is approved 3 months after the 3rd dose, and then a second booster is approved 4 months after the 4th dose. So technically now patients are due or have had received 5 doses of the mRNA COVID vaccine if they're like 12 years and older adults. There's slightly different recommendations for like the Pfizer and Moderna for like younger children, because as you know, like in like 5 years and younger, that was just approved this past summer. And then with the J&J, we're really phasing it out, but patients should have gotten a first dose of the J&J, then a booster, and then should have transitioned to like the mRNA vaccines. And then Novavax right now for primary immunodeficiencies older than 12 years of age, patients should get 2 initial doses and then a booster now too. And so this is just a study that my group did last year, just looking at initial immune responses in patients with immunodeficiencies to the mRNA vaccines. And so briefly, it was patients with typically more antibody deficiencies, because that's the most common immunodeficiency. And when we looked at T cell specific responses, so we took their blood and then tried to see if stimulating them against COVID particles and the virus stimulated an inflammatory response, immune response. And so for most patients, so the orange groups are, this circle is for CVID, and then the blue circles are for other antibody deficiencies. Most patients did produce a T cell response. So 80% of our patients with CVID and like 67% of our patients with other antibody deficiencies mounted a T cell response. Then we looked at antibody response. So particularly the spike antibody against spike protein, and then looked to see the neutralizing activity, so like the functional activity in that antibody preventing the virus from getting into the cell. And so that wasn't as great after 2 doses. But when we looked at patients with these immunodeficiencies after a 3rd dose, some patients, particularly patients with specific antibody deficiency or hypogam, they were blocking the virus to like the normal level. They were like blocking the 90 to 100% time, they were blocking about 90 to 100% of those viral entries. And so there definitely was a general trend towards a positive antibody response. And in general, after a 3rd dose of the vaccine. So I'm a really strong proponent of keeping up with boosters. And because we do know that many patients, even with immunodeficiencies, will respond. But there are other things to do as well if patients do not respond to vaccines. So there have been reported breakthrough infections after vaccinations, as we discussed before, and that tends to be higher with Omicron. But in general, it seems to be to cause less severe disease than in patients who are unvaccinated, tend to have lower number of symptoms, shorter duration of symptoms, lower likelihood of persistent symptoms for over 28 days, and they have a higher likelihood of being asymptomatic compared to those who are unvaccinated. And so this suggests that with the vaccine, protection to infection will decrease over time, but hospitalization and severe COVID protection still remains high, especially in those that receive boosters. And so you might have heard on the news that the FDA just authorized the new bivalent COVID vaccine boosters from Moderna and Pfizer. And so these bivalent boosters come right in time for most people to get their boosters for the fall. And so both of the boosters are split up into basically half of the old vaccine, or like the original vaccine, and then half of a new component that will target a new component of the Omicron variant, BA4 and BA5. They chose an mRNA component that was similar, shared between the two, to provide better protection against Omicron in general. And so the dosing, so for the Pfizer booster, it's approved for 12 and older, and the dose is the 30 microgram dose, which is the dose, the regular Pfizer vaccine dose, and for Moderna, it's the 50 microgram dose, and that's approved for 18 years and older. And so if you remember, the original vaccine doses for Moderna were 100, and then the booster doses are 50. And so the FDA made this decision based on the extensive safety and efficacy data of the original mRNA vaccines. And then there was a clinical study, like a trial in phase 2-3, that did study a new vaccine targeted towards the BA1 variant. And it showed that there was no inferior response against the original virus. And there was a good response against the latest variants, BA4 and 5. And then there's some preclinical data, so not tested through clinical trials, but they found that if they used the mRNA strain that they found was similar or shared between the BA4 and BA5 variant, then it had really strong neutralizing antibody responses against all Omicron, like BA1, 2, 4, and 5, as well as the original virus too. And so per the FDA, patients will likely be able to receive it if they're more than 2 months or more out from their last COVID primary dose or booster. Mixing between Pfizer and Moderna is okay. The CDC still needs to meet though. So they're meeting at the end of this week, so today and tomorrow, I believe, from what I read, to give formal recommendations. The US government has ordered 170 million doses. Like for here at UCSF, we put our orders in July. And so because we were really anticipating in general that this new update would be available for the fall. And so the anticipated rollout will be hopefully sometime next week, mid-September, but we'll see where things are. And so because of this update, most likely the monovalent mRNA COVID vaccines will not be authorized as an additional booster. So it would just be the bivalent, likely the bivalent booster moving forward. So definitely stay tuned. Stay tuned to the news and then your healthcare system as well with regards to updates when it would be available for administration. And so timing, we always get asked about timing. So with timing of the COVID vaccines and other vaccines, you can get it anytime. It's just you might feel, the thought is that like you might feel poorly if you get two more, but actually there was like a randomized control trial that didn't show that there was any increase in reactivity if patients got the COVID vaccine with the flu vaccine or COVID vaccine with placebo. But everyone's a little bit different, and but you can safely get multiple vaccines on the same day with a COVID vaccine. You can get it anytime with regards to IVIG and subcutaneous infusion. And then if you get the vaccine, then you have to wait 2 weeks to get Evusheld. If you get Evusheld or a monoclonal antibody, you don't have to wait anytime after that for the vaccine. And so that brings me to Evusheld, which is a medication that was made. Basically, these antibodies were made in a lab and engineered to be long lasting and to be targeted against the spike protein of COVID. And so it works to prevent infection, and that's how it's approved. And there's a lot of there have been a lot of monoclonal antibodies approved for post-exposure to COVID prophylaxis, preventative infection, and also there's some for treatment as well. This one is approved for prevention. And the medication, the antibody, has a half-life of 90 days, so lasts really long in your system. And so it's a 300 milligram dose of each component of so there's two components of the medication. And so it's 2 injections intramuscularly, typically the buttocks, and then usually like an hour monitoring or so after that. And the recommendation is to get a dose every 6 months. And people are constantly looking at the medication, making sure it's still active and against the variants that are out. And so if the activity changes, then recommendations will change as well. And of course, this isn't a substitution for COVID-19 vaccination, but offers a good offers a level of protection for patients who might not have good antibody responses or might not be able to tolerate certain vaccines. And so you might hear different names pop up over the COVID pandemic and over the last couple of years, but because there have been monoclonal antibodies going in and out of use because of their efficacy against the variants. And so many of those have we stopped using them, but Evusheld is still working and effective, and it's approved for people 12 years and older, and they have to weigh at least 40 kilograms. You can't have COVID when you get the infusion, and you can't have a recent exposure to COVID. And it's approved for patients who have moderate to severe immunodeficiency. And that you would think you would expect not to have an adequate immune response to a COVID vaccine. And so examples of that include patients who are actively on cancer treatment, patients who have received organ transplants, patients on immunosuppressive therapy, patients who have received CAR T-cell therapy, patients with moderate to severe immunodeficiencies, untreated advanced HIV, high-dose steroids. And so initially early on in the year, the availability, as we tried to figure out like where the medication should go, the availability was really triaged to really high-risk patients. That availability is now more broadly, like availability is greater now. And so definitely if you feel like you fall into this and would be interested in it, reach out to your providers to see if it would be available for you. And so in the original study of Evusheld, they studied it in 2021 in patients who had a risk factor for severe COVID. So patients who are older, who had obesity, heart issues, lung issues, kidney issues, or had high risk of exposure to COVID. And so in their trials, after an injection of the medication, they found that it compared to placebo, they had basically a 77% relative risk reduction in getting a COVID infection. And at 6-month follow-up, the reduction risk was still 82.3%. And all the severe cases and the COVID deaths only occurred in the placebo group. And adverse events were pretty equal in both placebo and the treatment group. And so most common side effects are headache, fatigue, cough. There's a risk of an allergic reaction. And so that's why they have you be monitored for an hour after the injection. And so if you've had a reaction to, let's say like an IVIG product or a monoclonal antibody, just definitely let the provider who's administering know. And they might give you some pre-medications if there's any particular concern. They did publish some data with regards to cardiac side effects, where the people in the Evusheld treatment group had 0.6% had cardiac events, like anything like a heart attack, heart arrhythmia, heart failure, anything. They grouped it into that. And then in the placebo group, it was 0.2%. And so, of course, these patients already were at higher risk and had a history of heart disease. And so it's unclear if it's from the medication itself or from just patients you would expect to already have issues. And there was nothing in particular, like it could occur 30 minutes after to 6 months afterwards. And so no particular concerning pattern. And I've had some patients who've had if with a more extensive history, talk to their cardiologist, but I haven't had any patients need not get the medication because of they just report it out of an abundance of caution. And so there have been some in vitro studies suggesting that Evusheld still retains functional neutralizing activity against Omicron, but likely in reduced levels. So this study was published recently, a couple weeks ago. And these are all the different monoclonal antibodies that we've stopped using because they stopped working as well against Omicron. And so this is the reference virus. So this is like the original COVID virus. And so they took the medications at different doses and tried to see at what factor did they suppress or like neutralize more than 50% of the virus. And so with the original virus, you can see like lower numbers, so like lower number than better. And so you can see that with the components of the Evusheld, the Tixa component isn't working as well against the newer Omicron variants, but the Silga component still has efficacy. And so it's still worthwhile for patients to get Evusheld. And this is the combination effect. And so that is an extra layer of protection for patients with immunodeficiencies and also immunoglobulin replacement and subcutaneous. Immunoglobulin replacement is likely having higher and higher levels of protective antibodies. So studies back in 2021 predicted that by now there would be protective titers. And typically it takes about 9 to 12 months for donated blood to be made into products to reach the patient for infusion. So it's about now that patients have been vaccinated. The patients who have been vaccinated and donated their blood, their products are coming up now. And so there was a interesting study published a couple of weeks ago where scientists took Hizentra, because they had Hizentra, and looked at antibody levels and also neutralization as well. And so they looked at different lots. So it's kind of small, but this is a lot from that expired in December 2022. And then this is a lot that expired in December 2023. And so it just went February, May, June, July, August. So like different dates. And as you can see, as the expiration dates moved further away, the COVID antibody levels higher. And this is the reference range for convalescent plasma of COVID antibodies. So as you can see, for the lots for Hizentra, for like this particular sample, the November 2023 and the December 2023 lots had antibody levels at higher rates even than convalescent plasma. And it did show that neutralization was detected too. And so always good to help prevent infections, but if you do get symptoms, it's good to get tested to know. And there's two main tests that we use to help detect COVID. And so they're the PCR tests. So they're high sensitivity and specificity. They do take some time to come back. But there's also home antigen tests. So those are rapid, look for the viral proteins and they're less sensitive. There's also blood testing, but that tends to look for antibodies that identify patients who have had COVID-19 in the past or in the past 3 to 4 weeks. And so limitations with Omicron, a single home antigen test might only be able to identify Omicron variant about 60% of the time. And so that's why now, especially, it's important to continue testing. And sometimes I've been seeing patients not become positive until day 4 or 5 of symptoms. And it's important to keep testing. And that's why a lot of testing kits come with 2. And so you would use that test within 24 to 48 hours. If you're really concerned and want to know so that you can like get therapy for COVID, it's important to get a PCR test. Sometimes that will take some time to return, but that's a better test for diagnosis. But of course, while you're waiting, you can continue to take home tests too. And then the blood testing, there's no real great validated way to test immune response that will reflect clinical response. That there are many tests out there, and they're not all standardized, and we don't really know like what an index result means or like what an antibody level of 1,000 against my protein. So not routinely recommended to send, but you can send it. It's just hard to interpret, and wouldn't use it as to factor into whether or not you need certain therapies or vaccination. So for treatment for COVID, it's recommended for patients who have high risk of progressing to severe COVID. And so I'm going to focus on outpatient therapy. So for outpatient therapy, you have to have confirmed COVID by testing. You have to fall, like the symptoms have to fall within the time frame for the therapies, and you have to have mild, moderate disease and not need to go to the hospital, and then have the high risk. If you're hospitalized, need oxygen that's new or worsening oxygen requirement, unfortunately, we'd recommend that you go to the hospital for evaluation and therapies there. So mild, moderate COVID, basically, if you have like a sore throat, fever, feel tired, cough, then that's mild. Moderate, you can have respiratory symptoms, but as long as you don't need oxygen, then are inpatient care, then you can qualify for this mild, moderate COVID. And so there's a ton of risk factors that are associated with higher risk of more severe COVID. So age now is 50 years and older, patients with lung disease, asthma, cancer, HIV, heart issues, primary immunodeficiencies, certain infections like tuberculosis, obesity, being overweight. So a lot of patients do qualify for therapy. And so really important for immunocompromised patients to diagnose that it's COVID and discuss with their doctors if you're on immunosuppressant medications, if they need to be stopped or reduced in any way. And then a lot of it is symptomatic care. But for the outpatient therapies, there's definitely a couple of medications approved for use. And so usually the first line of therapy we like to use is Paxlovid. It's a medication with 2 antiviral components in it. And so approved for people 12 years of age and older. And you have to get it in within 5 days of symptoms. And so you have to start the therapy within 5 days of symptoms. This medication, you definitely have to tell your provider in the pharmacy what medications you're on, because ritonavir particularly can interact with a lot of different medications. And patients with kidney issues, you would have to change the dosing, or you might choose a different product. And so it's an oral medication, which is great. You take it twice a day for 5 days. And in prior studies have reduced the risk of dying from COVID by 78% and decreased hospitalization by 73% in at-risk individuals. And it's it's expected to retain activity against Omicron. Main side effects of taking the medication, it tastes really bad, tastes really metallic, and some patients can get gut symptoms. But with stopping the therapy, it should get better. Things like cinnamon candies can help, eating and drinking can help too. Remdesivir is another antiviral that is approved for therapy for patients if they're within 7 days of symptoms. Can't be used in patients who have liver disease usually. And it's an IV medication that you need to come in for 3 days in a row, typically. If the patient's in the hospital, they might extend the therapy, but it's been shown to decrease hospitalization if you use it in mild, moderate disease, 87%. Generally well tolerated. And then bebtelovimab is a monoclonal antibody, which is another IV infusion that's approved for therapy within 7 days, approved for people 12 years and older, greater than 40 kilograms. And it's a single IV dose, and it's reduced symptom resolution from 8 to 6 days, decreased hospitalization and death as well. And so that study looking at the monoclonal antibodies show that bebtelovimab still has good protection and activity against it, at least in vitro, against the Omicron variants. And then you can still use convalescent plasma if you're within 8 days of therapy or with symptom onset. That requires IV administration as well, blood typing and testing beforehand. And then another oral pill that's available for patients is molnupiravir that patients should take within 5 days of symptoms, approved in adults. And it is 4 capsules taken twice a day for 5 days. And so this is good because it doesn't have medication interactions and you don't have to adjust for kidney or liver issues. You can't use it in younger kids because they have a higher risk of bone and cartilage issues, and not recommended in pregnancy or lactation. And if you are within like childbearing age or your partner, or like if anyone who's within childbearing age, talk to your doctor when you're on this medication, because there's certain things like steps for contraceptions that you need to take during therapy and after therapy as well. But it was able to reduce the risk of hospitalization or death by about 30%. And so, yeah, so other therapies like hydroxychloroquine, azithromycin, metformin, ivermectin, fluvoxamine are not active for COVID-19 based on the research we have. And then this is showing that the antivirals that I talked about are still effective against BA4 and BA5 in vitro in that study. And so rebound COVID, I'm sure some of you have heard about it, and it occurs when some patients have a reoccurrence of symptoms after an initial infection, and they can become positive again if they've become negative on testing. And so this has been shown to occur actually after a course of antivirals like Paxlovid or molnupiravir, but it also can occur without treatment as well. So in the Pfizer's initial clinical trials, they found that about 1 to 2% of patients who got placebo versus who got placebo and or treatment had rebound. And new studies suggest that in the Omicron age, that rebound COVID occurs more often. Some recent data suggests that maybe even 10% of COVID cases might have rebound. And so I'm sure you've heard President Biden had rebound COVID. And so not unusual, still rare, but we still don't understand why this occurs. Initially, there was like a theory that maybe if you treat it and then you don't have a good immune response, your immune response isn't able to completely clear the virus after that. But then it occurs also in people who don't get therapy. So we still don't really understand. The good thing is that with the rebound COVID, it doesn't tend to be severe. Repeat therapy with the antivirals or other COVID therapies is not recommended or is not part of the guidance for therapy. Long COVID, you might have heard about as well. When patients have symptoms that continue or return for at least 3 months after a person becomes ill with SARS-CoV-2. So from a recent June 2022 survey, nearly 1 in 5 patients with prior COVID infections reported that they have lingering symptoms that qualify them for a long COVID diagnosis. And so typical symptoms are fatigue, shortness of breath, cognitive issues, heart problems. There are studies that show that after COVID infection in general, there's more inflammation in your body, maybe higher risk of diabetes. But risk factors seem to be, if you're female, more females compared to men will get long COVID. If you have early lung involvement, if you have more severe COVID, if the patient's obese, has asthma, more poor general health, or is unvaccinated, those tend to be higher risk factors for long-term COVID. And the thought is that if you get more COVID infections, you have a higher risk of getting long-term COVID as well, because you get inflammation with each infection. It's unknown if PID patients are at higher risk. More information needs to be collected. And treatment now, there's nothing really specific for therapy except addressing the individual issue. Symptomatic therapy has seemed to help. Some people have looked into antivirals, but it's not anything formally recommended. And so from this talk summary, infections of COVID continue to be a health issue in our community and likely will be for a long time. And so good to know about ways to protect yourself. Variants will continue to emerge. Vaccinations and staying up to boosters can help prevent infections. Keeping with your IVIG infusions will be helpful. There are therapies available to prevent COVID, like Evusheld if you qualify. And then there are therapies available for patients who have a risk of severe COVID if you get COVID. And so we're learning more and more each day. There's patient registries that are collecting data for patients with immunodeficiencies who get COVID, and that will be particularly helpful in understanding COVID in patients with immunodeficiencies as well. Thank you.
Oh my goodness, wonderful information. Thank you so much. And thank you for just being here, knowing that you are recovering from an illness yourself.
Oh yeah, hopefully you understood, like, was able to communicate well. Okay.
Yes, well, we are the right community to understand illness. So thank you so much. And we're used to fighting through it ourselves. And thank you so much. Okay, so we are going to take just a quick break with our sponsors. We have CSL Behring, Takeda, Accredo, and X4 Pharmaceuticals. And we have some short videos from each of these wonderful sponsors that we're going to share. And then we will be right back with Dr. Pham and Colleen Brock for the Q&A.
For more than 100 years, we've turned innovative thinking into solutions. CSL's investment in innovation has helped to develop a robust pipeline of safe and effective medicines and improve existing ones so that we can bring patients meaningful innovations and advancements that make their lives better.
My name is Dana Fladhammer. At Takeda, I am the Director of IG Community Support. You might know the team I'm lucky enough to be a part of as the MyIG Source Patient Advocates. I know that throughout my journey as a mom of 4 children living with primary immunodeficiency, the IDF has been simply an invaluable resource to me. I hope you learn a ton, and if you need us, know that nobody should ever have to do this alone.
Welcome to the IDF Forum. I am Kim Farrell, Product Line Manager with Accredo. Accredo is a best-in-class specialty pharmacy with a nationwide network of immune globulin-trained home infusion nurses and pharmacists. It is truly an honor and privilege to be part of this immune deficiency community. Accredo places patients at the center of all we do. We deliver individualized care and support for patients living with immune disorders. It's all about giving you a great and personalized pharmacy experience.
X4 Pharmaceuticals is developing therapies for people with two types of PIs, WHIM syndrome and chronic neutropenia. These two communities would not have had access to resources like this at Forum without the IDF. We're incredibly grateful for everything that IDF does for the PI community and that we can be a part of it. If you'd like to learn more about our ongoing clinical trials or about our no-cost genetic testing program for those with neutropenia, you can email patientinfo@x4pharma.com. Thank you, IDF.
And at this time, I would like to introduce my colleague, Colleen Brock, who is Manager of Medical Programs at IDF. She is going to moderate the Q&A session, and Colleen and Dr. Pham, take it away.
All right, Dr. Pham, we're going to rock and roll. Let's see how many we
did,
can get through.
I did see an important question that I addressed about the booster. So patients are eligible for their 5th COVID booster 4 months after their 4th dose. But with the new booster, because it's a new vaccine, half new, likely we will be available, or it will be available for patients within 2 months out from the dose.
Yeah, I did see that. So thank you for clarifying that. Okay, so question number 1 and 2 have to do with children. What is the latest with COVID presenting in immunocompromised kids aged 2 to 5?
I don't know the latest information with regards to Omicron, specifically in pediatrics. I would imagine it would be similar with similar symptoms in PID. I would say that typically Omicron in general seems to be a little bit milder. And so I would think like fever, sore throat, runny nose, cough in those patients. But it also depends on the CVID or the PID and what other comorbidities as well. Particularly like a child who's waiting for a transplant or post-transplant would be higher risk for more severe infection than, let's say, like a IgA deficient patient that's or something like that.
True. What does somebody do that is not able to get the vaccine? How do they protect themselves?
Yeah, if you're not able to get the COVID vaccine because you have a medical exemption, like you're allergic to the vaccine or have had a severe reaction. So good thing is there's other types of vaccines as well. So Novavax is a different type of vaccine that you can get, but potentially depending on where you are, you could see if your institution will allow you to get Evusheld as a therapy. Some institutions request that patients are be fully vaccinated. Some will use it in patients who are unable to get vaccination. Some will give it to anyone who has immune deficiency. So it depends.
Okay, thank you. Have you heard of patients with a PI not developing antibodies after having the infection?
Yeah, so patients who have immunodeficiency that don't make antibodies like XLA, or who don't make good ones like hyper IgM patients, they don't make good IgG antibodies, IgA antibodies. And so we wouldn't expect them to make antibodies after infection. We would expect them to make T-cell responses, though, so still some immune protection.
Okay. And then here's sort of the flip side. Have you heard of people who have COVID, but are testing negative even on a PCR test? And they have every symptom in the book.
Yeah, so that's hard to say because there are a lot of other viruses going on as well. Like I tested multiple times negative for COVID. And there's like rhinovirus, RSV, the flu was very interesting this past year. Like I was seeing flu cases up until like June, July. And so there could be a lot of different viruses that have similar symptoms or infections that isn't COVID as well.
Okay.
Fortunately for the therapies, you have to have a COVID confirmation. There are some reports now of like low level of COVID, like low COVID viral levels. And so it'd be a little bit trickier to catch, but then you would just continue testing to see.
Okay. Are you predicting that the vaccines and COVID will become a seasonal thing like the flu?
I do.
If you had Delta COVID a year ago and still have no taste or smell, do you think it will come back for this person?
I hope so. Studies have shown, well, so that we've only had COVID for the past 2 years or so, but about 60% of patients with a loss in taste and smell have improvement, or it comes back after a year. So there's still time, and there's still a good chunk of patients though that still have long-lasting issues with smell. And we've seen this before in patients who have severe flu infections, like with the flu. We definitely have patients who have lost their sense of smell, but maybe in a couple of years of that time, hopefully.
Okay. Is it necessary to wear goggles to prevent contracting COVID?
Not necessary, but it is something that would add more protection. We do know that COVID can spread through mucosal membranes, and so your eyes are a mucosal membrane, but we only use it really in like clinical setting, like because we see patients, we look in patients' mouth, it's a higher risk situation. And so we don't wear goggles, but we wear like eye shields. But it's not necessary, like going on a walk or going on.
Okay. What treatment is recommended for someone on blood thinners or statins? Can they get the Evusheld, the vaccines, Paxlovid, or are there things they should stay away from?
Yeah, so I guess just blood thinners and statins. So you definitely can get the vaccine. That's not an exclusion for the vaccine. Evusheld, so blood thinners, there is a warning with regards to like if you are more prone to bleeding because it's injected in a big muscle, you can get a bruise there. And so definitely to talk with the provider that you're talking to about ordering it, about whether or not it would be like the risks would outweigh the benefits of Evusheld. And then all the therapies, it really depends on statins. You do have to hold it for Paxlovid, the antiviral, but just make sure the providers that you're seeing know for you, and they can help you think through what's available.
There have been a tremendous amount of people who would like to know, are our IG replacement therapies protective?
Yeah, we don't have enough data available yet, but per the models, predictive models, and the Hicentra paper that I showed, does seem like we have likely at this time that products will have good protective antibody levels. And so it depends, like that was only in Hicentra. Other people, other companies will look at their products as well and check and hopefully publish their results. But I would imagine that as time goes on and people continue to get vaccinated, the antibody titers will continue to persist in IVIG and subcutaneous.
But is it to a point where we should not be vaccinated, we should not get Evusheld, and we should just rely on our treatment?
I see. At this time, I would still recommend all of the therapies if you I would still recommend vaccination, especially because if you can mount an immune response through like your T cells, your other immune cells, that can give you extra protection because you need T cells to clear the virus. And IVIG only gives you antibodies. And the good thing about, I guess, with regards to getting the vaccine is your immune system is smart and it can change the response and the antibodies it makes against the vaccine. So you can make like a ton of different types of antibodies as well. And so it just increases the diversity of your immune response if you keep getting vaccinated.
Perfect. I have IgM deficiency. If my blood test shows high levels of antibodies after my second booster above the max level of the test, does that mean I'm unlikely to get sick?
Hard to predict. We don't have reference ranges that are linked to clinical protection. Like in the study that we did in like the initial patients. So we kept checking for antibody responses and neutralization activity, even in the Omicron stage and even with Evusheld. And so we do know that after Evusheld, these patients tend to get like spike protein antibodies in like 10,000, 20,000, and the neutralization activity is like 90 to 100%. in blocking the virus. But we do know that some of those patients still got infected. And so this Omicron virus is a little bit more invasive. And so even if your antibody levels are high, it doesn't necessarily mean 100% that you won't get it. It just gives you a little bit more reassurance that you're like the rest of the population.
Talking about vaccines, several people asked about autoimmune flares. Are you seeing that with people who are vaccinated?
So it's interesting. So I'm also an allergist as well. And so I see the other side of things. And we definitely have seen some patients get like hives after the vaccine or eczema flares. Rheumatologists and neurologists and patients with MS, they still in general recommend the COVID vaccines because the risk of inflammation from the infection itself is worse than the inflammation generally from the vaccine. So generally it's recommended for all those patients with autoimmune history to get vaccinated, but we have seen some cases of autoimmune issues with this vaccine.
So let's talk about Evusheld. Why do some immunologists not recommend it for their patients? Why do some say if maybe you have antibodies from the vaccine, so you don't need it?
Yeah, so some patients might not need it, even with immunodeficiency. That's why it's recommended for patients with moderate to severe immunodeficiency. And so there's some patients with, let's say, CGD. So I expect their antibody responses to vaccines and T-cell responses to vaccines to be normal. And so I have not been recommending Evusheld for CGD patients. And so patients with like milder antibody deficiencies, I haven't been routinely recommending it. So it really depends on you as a patient, what your clinician thinks your risk is.
And so do you recommend the boosters and Evusheld? Somebody says, I've not had the boosters because my oncologist said to get Evusheld instead.
I see. Yeah, so it really depends on you as an individual, like what's going on and what went into that recommendation. But in general, let's say like for my CVID patients or specific antibody deficient patients, I've been recommending, and those patients are on IVIG, I've been recommending Evusheld to give them an extra layer of protection with antibodies because but I'm also recommending the vaccine as well because they might respond to the vaccine and make antibodies, but maybe those antibodies aren't as quite a high of level as I would like, or the immunity will wane over time. With Evusheld, the protection does last for 6 months. And so it's something to consider, but I always still recommend the vaccine because it can teach your immune system loss.
Well, and somebody asked, since the half-life of Evusheld is 90 days, does the strength and efficacy of it decrease after 90 days, even though you don't get the second one for 6 months?
Yeah, so in the trial, they checked efficacy at six months, and it was still 82 or something percent effective. So that, like, and then immediately after that, it was like 70, 79%. So pretty close.
And how does immunosuppressant medication affect the vaccines and Evusheld effectiveness?
Yeah, so immunosuppressive medications will suppress any immune response or some immune response that you will have to the vaccine. And so your antibody production might not be as good, your T-cell responses might not be as good. Immunosuppressants will not affect Evusheld because Evusheld, you're just getting those antibodies. And so it wouldn't affect the levels that you absorb.
Now talking about people who have been sick with COVID, what do we know about how long one might be safe after infection? So if I'm getting over it, I'm done. Am I not going to get it for a month, 2 months, 6 months? Am I good to go till the next variant? What do you think?
Oh, gotcha. So I guess this calls into the data with regards to reinfection. It's been changing with regards to the variant. And so Omicron is much more infectious compared to, say, Delta or Alpha. And so there's a 30 time greater risk of getting reinfection now. It's unlikely that you would get an Omicron infection again within a month, but there is some potential that you could get it in 3 to 6 months when your immunity decreases and the variant changes.
And then kind of following along those lines, at what point should you start masking up again then?
So in patients with immunodeficiencies, especially moderate to severe, I've still been telling or recommending that indoors patient mask if they're like with other people that they don't know whether or not they have COVID or it's like a gathering. Outdoors, it's less likely to get COVID. And so I don't think it's particularly necessary unless you like aren't going to be in close proximity. Like going to a crowded concert is not, because of a much higher risk activity than going on a walk to the park. And so I still recommend masking in certain situations for my PID patients.
And should you wear it like after you've been infected? Can you go out without it for 30 days and sort of feel okay, or should you still wear it?
Always better to be prepared, but I guess like within like a couple of days of infection and a couple of weeks, you have more protection. Unless you're the type of patient who doesn't make antibodies, then it would just be your T cells protecting you.
Okay. How do the COVID therapies interact with antibiotics or our IgG therapies? Do they have any, they don't change the effectiveness of the therapies or the medications?
No, they're not thought to. Yeah.
Perfect. All right, Paxlovid.
Mhm.
Can it be crushed? This person can't take pills.
Unfortunately, it's not recommended to crush them.
Okay.
But it could be, you could like, patients can get like remdesivir or the monoclonal antibody as alternatives too.
And I know we talked about the rebound in Paxlovid, but if you get sick, you take the Paxlovid, then let's say you get infected again in 6 months. Can you get Paxlovid again? Like how many times can you take Paxlovid?
Yeah, you can take it. There's no limit on how often you can take it, but we don't give it for rebound generally. Like there's no recommendation to. But if you had an infection then 6 months later, you had an infection, we would just consider that a different infection.
Do you know of any other monoclonals like Evusheld being developed?
Not that I've heard of, but I'm sure a lot of companies are working on monoclonal antibodies because there have been so many over the past 2 years, and all of it goes in and out depending on efficacy. And so I'm sure there's someone working on one targeted against Omicron.
All right, down to the last part.
Mhm.
Interesting question. How do I sanitize laundry using a public laundromat so I don't contract COVID?
So I guess in a laundromat, well, so I guess infections in general from fomites or like surfaces are unusual, low risk. It's generally through like respiratory droplets. Like if you were, let's say like someone sneezed on something, you touched it and then you touched your eyes or mouth or something, that would be higher risk. From I guess in laundry in a laundromat, you could think, so we recommend washing your hands for 20 seconds with soap. And so washing your laundry is much longer and you're using a detergent. And also the heat as well potentially could affect it. Hard to say. I don't think that anyone's really studying it, but I don't think it's particularly high risk practice.
Cool. Travel. Going to travel internationally in January of 23 and also travel in the country here. Any recommendations?
Yeah, so for my patients who've been traveling, with travel, like on the airplane, the airports, I do recommend wearing a mask and 95 if possible, if you have that, or a KN95, bringing test kits in case, and then having a plan if you were to get sick, where you would go. Because then there's so many therapies available now that you'd want to be able to have the option if you needed it, or be able to know where to go if you needed to seek care too. But yeah, it's great that people are able to travel more and be able to engage more in things. It's just being prepared if something were to happen, you were to get sick. And with travel, it's always with anything really, like going back to work, going to school, it's always your acceptance of the risk and the balance of the risk and the benefits you get from engaging and like going to a dinner with your family. And so always good to be prepared and decrease your risk as much as possible. And so keeping up to date with boosters will be helpful if you travel. So a lot of my patients are going to travel in the fall. And so they're really anticipating giving this new Omicron booster to give them an extra protective level too.
One last question, and I think this person sums up so many people, and it jumped out at me. I'm trying to figure out what is safe to do outside of the house. My husband keeps asking me to do things with him, and I don't know what to answer at this point. What amount of risk tolerance should I allow myself? I've not had COVID, probably guessing they don't want COVID, but they want to leave the house. And there are more that have said, I haven't left my house. I'm afraid to leave my house. How do I know it's safe to leave my house? What do you say to these people, how to move forward?
Yeah, it's definitely a hard transition because we spent the past 2 years being very isolated in general. But I think, so COVID will likely be part of our lives for a really long time. And we have to really figure out ways that we can live like a full life and be able to live with COVID in our midst. And so I think it's definitely going back to like your acceptance of the risk of getting sick and what your tolerance of that is, and your risk factors as well of getting severe COVID. But I think it's great that there's so many therapies available now to help give you extra protection. So with the vaccinations, they're like targeting the vaccines more towards the variants that are out. With regards to Evusheld, that can give you some more protection with antibodies. Hopefully other monoclonal antibodies will be approved. And then with IVIG having more antibodies as well, that should give you a little bit more of a buffer as well. And so with like Omicron, in general, the infections haven't been as severe in the general population, but of course, if you have comorbidities, it's riskier. But I wouldn't say that I would try to not live your life hinged on fear, and try to, I guess, strike a balance. And I know it's really hard. It's like easier to say than actually do. But I think it's just trying to figure out what matters to you, like visiting grandchildren. Of course, that's really important. And so finding that for you. And then all the therapies out there too. I think we're very thankful for the therapies because with the surge in the winter, and then now with Omicron being so infectious, the therapies are more readily available. And maybe that's why too that we haven't seen as many cases of severe COVID compared to what we would expect. But if cases are low and like are stable or plateaued, I think it's reasonable to think about engaging more. If it like cases are like in last December where they're super high, good time to like read a book and hang out with those for a little bit. But
yeah, stay home. Otherwise you can go out.
Yeah.
Well, thank you. That was tremendous. And I know your voice is probably very strained, but if you have questions, like I said, that we didn't get to, Ask IDF is here to help. We can help to answer those questions that you still have. I encourage you to watch the recording when it comes out, because I know there was so much information tonight. It's probably going to take another viewing or two to digest everything that we have learned this evening. But thank you, Dr. Pham. You have been amazing. And I appreciate everything that you have done, especially not feeling well.
Oh, of course. And then I saw one last important question. So the timing of Evusheld and monthly IVIG treatment, anytime. Anytime. Okay, great. Thank you for having me.
Oh my goodness. Well, I echo Colleen's thank yous, and the get well wishes and thank yous are coming in like crazy via the chat, Dr. Pham. So, you know, we so appreciate you and wish you all the best. And thank you so much for sharing this wonderful, valuable information with us tonight. I would also like to thank our featured sponsors tonight: CSL Behring, Grifols, Takeda, Accredo, Farming, and X4 Pharmaceuticals. Thank you so much for your support. And as always, every single one of you that joined us tonight, thank you. Thank you for being here. Thank you for sending your questions before the forum, during the forum, and we look forward to seeing you in a couple weeks. Good night.